Today, the topic of our discussion is on the abdominal tuberculosis. So today, in today's lecture, we shall be discussing details about what is abdominal tuberculosis, the etiology, okay, the roots of spread, the pathology. Then we shall be discussing about the clinical features, complications, investigations, and the treatment. So first, let us see what do you understand by abdominal tuberculosis. See, when the term abdominal tuberculosis is used, it involves the gut, the abdominal lymph nodes, and the peritoneum. Okay, so all these three things will be included in today's discussion. If the question would have been only, if someone asks you only about intestinal tuberculosis, you have to mainly focus only on the portion, this abdominal tuberculosis, as I told you, when we are talking about abdominal tuberculosis, we shall talk about all these three. Only intestinal tuberculosis, then you shall talk only about the intestinal tuberculosis. I'll tell you about these three things, okay? The three types of intestinal tuberculosis. So you have to focus on this thing. So let us see, what do you understand by abdominal tuberculosis? So just now, as I told you, it indicates the tubercular involvement of the gut, the intestine, the lymph nodes, and the peritoneum. Okay, so either individually, like either if only the intestinal tuberculosis, only the intestine is involved, okay, either it can be individual involvement or it can be in combination. Clear? So let us first talk about this intestinal tuberculosis. Remember, which part of the intestine is mainly involved by this Mycobacterium tuberculosis? It is the ileocecal region. Remember the ileocecal region, this is the most common region which is affected by the tuberculous bacteria. This region is affected in nearly 70% of the patients. Why is it that the ileocecal region is mostly affected? Because in this ileocecal region, there is increased stasis. Okay, there is increased physiological stasis, and there is a lot of lymphoid tissue in this region. Okay, so this is because the reason why the ileocecal region is most commonly affected. Okay, here in this region, there is increased fluid and electrolyte absorption, okay, increased stasis, a lot of lymphoid tissue is present, abundance of lymphoid tissue. Okay. Next, let us talk about the what is the etiology. So etiology, from the name only you can understand, it is caused by the Mycobacterium tuberculosis. Okay, so it is caused by the Mycobacterium tuberculosis bacteria. And what is the roots of spread? Okay, so from where does this tuberculosis bacteria reach the intestine? It can reach the intestine directly, by ingestion of bacilli in sputum. Right, suppose an active TB patient, if you are ingesting the sputum, ingestion of bacilli in the sputum, that can cause. Or suppose there is a primary focus in the lung, okay, in the lungs, okay, so that is the primary focus, okay, so that is in the lungs, and it was like later the reactivation occurred here, and then from there can occur hematogenous spread. Okay, the primary focus is in the lung. From there, through the hematogenous spread, it can affect the intestines, right? Or it can directly spread from any adjacent organs or through the lymph channels. Clear? Similarly, talking about the peritoneal, from peritoneum, how did this bacilli reach the peritoneum? Same way, it can spread directly from the lymph nodes, or it can spread from these intestinal lesions. From this intestine, first it will affect the intestine. From the intestinal lesions, it spreads to the peritoneum. Clear? So these are the ways how how the spread of this bacilli takes place. Intestinal TB, as I told you, the direct ingestion of bacilli in sputum, or through hematogenous spread or direct spread. Okay, so this is how the bacilli reaches these different organs. Right. Next, let us talk about intestinal tuberculosis. Intestinal tuberculosis, as you can see, I have written down, it is mainly of three types. One is your ulcerative type, right? From the name only you can understand. Ulcerative types means there are, in these patients, you will find multiple superficial ulcers. Okay. Then you have got a hypertrophic type. Remember, ulcerative type is the most common, 60%. Hypertrophic type is 10%. Another, you have got ulcerohypertrophic type, means in this you will have a combination of ulcerative and hypertrophic type. I'll show you the pictures here. So you can see here these ulcers. Okay, so you can see this tubercles, okay, the tubercles, okay, so which is present on the serosal surface. And here you can see the ulcero-hyperplastic growth in the cecum. Can you see the ulcers? Plus there has also occurred a growth, okay, so in the cecum. So this is your, first let me just tell you what is ulcerative type. See, ulcerative type when there are presence of multiple superficial ulcers, mainly in this ileocecal region. Okay, and one more thing you need to remember in this ulcerative type, because there are some certain other diseases also where you will find ulcers in the intestine. For example, can you just name of any disease where you will find ulcers in the intestine? Yes, in case of typhoid also there is presence of ulcers in the intestine, but the difference is that, remember, in case of the tuberculous ulcers, the long axis of the ulcers, this is perpendicular to the long axis of the gut segment involved. Whichever segment of the gut is involved, the ileocecal segment is involved. Okay, mainly as I told you, maximum cases, 60-70% cases. Okay, mainly it is the ileocecal junction which is involved. So the ulcers, the long axis of the ulcers, that is perpendicular. Okay, that is perpendicular to the long axis of the gut involved. Okay, and what happens is that when these ulcers, okay, the ulcers which is present, okay, so when they start healing, first initially there'll be ulcers, okay, and then when these ulcers, they start healing, when the healing of these ulcers takes place, this is peritoneal, okay, just 1 minute. Yes, when these ulcers, okay, they start healing, that results in strictures. Okay, there will be, suppose whichever segment of the, suppose I'll see you the segment of the intestine. First initially, okay, so there were ulcers here. Okay, the long axis of this ulcers lying perpendicular to the long axis of gut, and later when they will start healing, it will result in strictures, and due to the strictures there will be the narrowing of that particular part of the intestine, right? Yes. Next, come to hypertrophic. What is the meaning of the word hypertrophic? Hypertrophic actually, what's the meaning of the word hypertrophic? Hypertrophic means there is some mass, local hypertrophic mass, isn't it? So hypertrophic, remember, mainly the ulcerative type is found in the malnourished adults. Whereas this hypertrophic type, this is found in the well-nourished adults. So what happens in the hypertrophic mass? Often that, the scarring and fibrosis. Okay, so this occurs, as well as there is the presence of a hypertrophic mass. So often seeing this mass, sometimes we get confused with malignancy. Right, next come to this one, this ulcero-hypertrophic type, where it is a combination of hypertrophic and ulcerative type. So here, as you can see, there is the mass. Often there is a presence of a right iliac fossa lump. Okay, and this is this ulcero-hyperplastic growth in the cecum. So mainly, as I told you, there are 3 types of the intestinal tuberculosis. Okay, next let us talk about the next let us talk about the peritoneal tuberculosis. Just a minute, I just want to show you the pictures here. Okay, so next, let us talk about the peritoneal tuberculosis. As I told you, this I showed you the ulcerative hyperplastic. Yes, this is your peritoneal tuberculosis. So peritoneal tuberculosis, as you can see, the peritoneum. Okay, so you can see this peritoneum, and can you see this multiple white, yellow-white tubercles on the peritoneum? Okay, this multiple yellow-white tubercles on the peritoneum. So this is how the peritoneal tuberculosis looks like. You know, this peritoneum, it becomes thickened. Okay, and this omentum, okay, so this is also thickened, and there is presence of these multiple yellow-white tubercles, right? And this also, it occurs in 3 forms, peritoneal tuberculosis. One is your wet form, wet type. Okay, so it, in this wet type, this patients in this wet type of peritoneal tuberculosis, they mainly present with ascites. Okay, I'll repeat all these things once again. Just first have a basic idea. Wet type, this usually presents with ascites. Next, you have got the encysted or loculated type. Okay, so in the encysted type, okay, so what happens is that there is a localized abdominal swelling. Okay, so localized abdominal swelling. Then you have got your fibrotic type. Okay, so fibrotic type, in this fibrotic type, you can feel lumps in the abdomen. Okay, so it presents with abdominal masses, and this abdominal mass, this is mainly composed of this omental thickening. This omentum, it becomes thickened. Okay, there is thickening of the mesentery, there is thickening of this omentum, and this omental and mesenteric thickening only that presents as masses. Okay, when you palpate the abdomen, you can find lumps and masses in the abdomen. This is nothing but simply the thickening of this omentum and the mesentery. Clear? So this is all about your peritoneal tuberculosis. Okay, I'll again discuss again briefly about it. So what did we say just now? We saw intestinal tuberculosis, mainly three types, as I showed you. The ulcerative type, okay, so where there are mainly the presence of ulcers, superficial ulcers, multiple superficial ulcers, mainly on the epithelial surface of the ileocecal area. And when these ulcers, they start healing, that will result in strictures. Okay, then hypertrophic type, here there is mainly the presence of a local hypertrophic mass. Ulcerohypertrophic type, that is the combination of the ulcerative type and the hypertrophic type. Clear? Next, we discussed about the peritoneal TB. I showed you those multiple white, yellow tubercles present on the peritoneum. Okay, and the peritoneum that becomes thickened, and the omentum is also thickened. Okay, so this peritoneal TB, this mainly occurs in three forms. As I told you, one is your wet form. Okay, then is your encysted type. Another is your fibrotic type. Wet form, that mainly presents with ascites. Then you have got your encysted type. So here there is the localized, just one simple, localized abdominal swelling. In the fibrotic type, there are multiple abdominal masses. Okay, so when you palpate the abdomen, because of this thickening of mesentery and omentum, you'll find abdominal masses. But encysted type, you'll just find a localized abdominal swelling. Okay, so that is the main difference in encysted and fibrotic types. Right, so this is about your peritoneal tuberculosis. Next is the lymph nodes which are involved. Okay, which lymph nodes are mainly involved here? The mesenteric lymph nodes, the omental lymph nodes, okay, the peripancreatic lymph nodes. So all those lymph nodes are involved in this, and it is mainly seen in young adults. So these are the three types of abdominal tuberculosis. Clear? Okay. Next, let us come to the clinical features. How does the patient present to you with? Remember, first the classical presentation of tuberculosis. What is the presentation of tuberculosis? The classical presentation of tuberculosis: fever. Okay, there is weight loss, anorexia, malaise. This all you must be knowing. Okay, there is fever. Sorry, fever, weight loss. Okay, so there is anorexia, malaise. Okay, so these are the common symptoms of tuberculosis, as all of you know. Apart from this, since the intestine and these structures are involved, therefore the patient will have diarrhea or constipation. Okay, some patients suffer. Usually the patients suffer from diarrhea. Okay, diarrhea or constipation. And what else? When the slowly, when the lymph nodes, they start getting involved, the patient starts complaining of colicky abdominal pain. Why colicky abdominal pain? Because as I told you, after the development of ulcers, often they develop strictures in the luminal strictures. Okay, so because of these strictures, there can occur colicky abdominal pain. Clear? So, and what else? Abdominal examination, as I told you, if it is a hypertrophic type, or if the multiple lymph nodes are involved, okay, so, or if there is any localized abdominal swelling, or if there is omental thickening, then you can palpate and you can find some abdominal masses. Not in all the cases. In those cases which I mentioned above, that you can feel for the abdominal masses. Okay, and if there occurs ascites, then you will get abdominal distension also. If the patient, if there has occurred ascites, there can also occur abdominal distension. Clear? So these are some of the clinical features the patient is going to present to you with. Okay. Next, let us talk about the complications. Okay, what complications can develop? So complications that can develop is that, you know, these ulcers, which is present. Okay, so these ulcers, okay, so which is present. Okay, so these ulcers, they can cause perforation of the intestine. Okay, so perforation. Intestinal perforation is a very common complication. What else? Hemorrhage. Okay, and as I told you, when these ulcers, they start healing, then what happens? There starts occurring strictures. Okay, there starts occurring, there will be the development of stricture. Stricture will cause the narrowing of the lumen, so that can cause intestinal obstruction. Okay, so this is one more complication which can develop. What else can develop? There can develop malabsorption. Why they'll develop malabsorption? This different, you know, the portions of the intestine is involved, mainly the ileocecal junction, and you know, whatever absorption was taking place from that particular area which has been affected by tuberculosis, so it will result in malabsorption, isn't it? If any part of the intestine, in the intestine, mainly the absorption of nutrients and everything takes place, right? So if the part of the intestine is affected, so obviously there will be malabsorption. Clear? And what else can occur? Yes, apart from this, there can be hemorrhage. I told you, hemorrhage, perforation, intestinal obstruction, malabsorption. There can also be fistula formation. Okay, so often between these two loops of the intestine, okay, so there can be fistula formation, or between the intestine and the skin. Between the skin and the intestine also, there can be the formation of fistula. Okay, so fistula formation, this also can occur. So these are the different complications which can occur. Clear? Next, let us come to the investigations. So investigations, first, let us look at the basic investigations. Obviously, we are going to do a CBC. We are going to look for the ESR in these patients. The ESR is raised. Okay, and anemia is often present. The albumin levels, okay, that is often decreased. Hypoalbuminemia. Then we go for the chest X-ray, because sometimes, as I told you, the primary focus is in the lungs, from where the hematogenous spread occurs. The chest X-ray, either it will show an active lesion, tubercular lesion, or it can show a old tubercular lesion. Then we are going to carry out the plain X-ray of abdomen. What is the plain X-ray of the abdomen going to reveal? If it can show some calcified lymph nodes, okay, or if there has occurred any obstruction, as I told you, in the intestine due to the strictures, there can occur obstruction. If there has occurred obstruction, you can see the dilated bowel loops. You must have seen a case X-ray of intestinal obstruction. So there we find the dilated bowel loops. Okay, so there are multiple air fluid levels. These all you must, very common X-ray of intestinal obstruction, multiple air fluid levels. These are seen in the X-ray. Next, come to the barium meal. So barium meal, I have got some pictures of barium meal. What are the things which you are going to see in barium meal? So in barium meal, just a minute. Yes, these are some of the signs, some things which you know, signs which you can see in the barium investigations when you do the barium meal. So in the barium meal, often we find, can you see this hypersegmentation of the barium meal? How it has got segmented like this segmentation, hypersegmentation. So this hypersegmentation of this barium column, this is also called as chicken intestine. Okay, so this is what is also called as chicken intestine. These are very typical features which you see in case of this intestinal tuberculosis. Okay, so chicken intestine, this hypersegmentation of this barium column. Okay, what else can you see? You can also see hourglass stenosis. Suppose anywhere the stenosis has occurred. So prior to the area of stenosis, there will be dilation, and below the area of stenosis, there will be dilation. So there will be something like this. Okay, the hourglass. Okay, so above this area, suppose the stricture has occurred in this area. Okay, so above the area there is going to be dilation, and below the area there will be dilation. Okay, so of the intestine. So this is called as the hourglass stenosis. Okay, so these are the things which you are going to see after giving the barium meal. What else you can see? Again, if there are strictures, this is just one thing I've shown you, chicken intestine. Apart from this, I'm just telling you can also see hourglass stenosis, and you can also see multiple strictures. If there has, if you know, there were a lot of ulcers which has healed and it has caused multiple strictures. So accordingly, you can see the multiple strictures in the barium meal. Multiple strictures. Okay, then there is something which is called as the Stirling sign and string sign. Two are different. One is Stirling sign, another string sign. Since string sign is shown here, can you see what is the string sign? Can you see? It's just a narrow, segment. Can you see here? So what is the string sign is that in the terminal ileum, this is the terminal ileum. In the terminal ileum, you can just see a very thin stream of barium. Okay, because there has mainly occurred stricture in this portion. This lumen is completely occluded. So little bit of barium has passed through it. So you can just see a very thin stream of barium in the terminal ileum. This is what is called as the string sign in tuberculosis. What is Stirling sign? Stirling sign, actually what happens in Stirling sign, this is also a feature which you can see, a sign which you can see in radiographically. Here what happens, due to the irritation of the cecum by the bacteria, here the cecum, okay, so there occurs the irritation of the cecum by the bacteria. Therefore what happens is that there occurs repeated emptying of the cecum. Okay, there occurs repeated emptying of the cecum because of the irritation of the cecum by the bacteria. Okay, so these are the different signs. Again, let me tell you, string sign and Stirling sign are not very specific for abdominal tuberculosis. You can see these two signs also in case of Crohn's disease. Clear? Okay, next, what else other investigations can we do in these patients? Yes, we can do abdominal ultrasound. So in ultrasonography, what can you see? You can see if there is any ascites has developed. Okay, or I'll show you one more thing which is called as interloop ascites. Yes, see, this is ultrasonography which is done, and can you see between the loops of the intestine, here is your ascites, the fluid. Okay, that is your interloop ascites. This is also called as the club sandwich or sliced bread sign. Club sandwich. This is the feature sign which you get when you do the ultrasonography of the abdomen. Okay, so club sandwich or the sliced bread sign. So what happens in this? Okay, just a minute. So I just showed you the club sandwich sign. For some reason, for pics are not opening. So anyhow, I just showed you, all saw what is that, the interloop ascites or the club sandwich sign. So when we do the abdominal ultrasonography, there we can see these signs, the club sandwich sign, the presence of ascites in between the loops of intestine. Okay, you can see if there has developed any, intra-abdominal fluid, ascites has developed or not. Okay, whether there is enlargement of any lymph nodes. Okay, so lymphadenopathy. Right, or whether there has occurred any bowel wall thickening in the ileocecal region. Okay, so if there has occurred any bowel wall thickening in the ileocecal region, wall thickening, the eccentric wall thickening, the lymph nodes, the adenopathy, okay, the fluid, the interloop ascites, presence of ascites, the thickening of the cecum. Okay, all these things can be seen in the ultrasonography. Clear? Then next come to more specific is your CT scan. In CT scan, you can more specifically can see this thickening of cecum and the terminal ileum, the thickening and lymph nodes and mesenteric thickening. Okay, so that can be even more ascitic fluid. Okay, where the ulceration, the omental thickening, lymph nodes. Okay, so the thickening, the enlargement of lymph nodes, lymphadenopathy, all those things can be more specifically seen in the CT scan. Right? And then we are going to do the ascitic fluid examination. We are going to tap the ascitic fluid if there is the presence of ascites, and we are going to do the fluid examination. What else? We are going to, we are also going to carry out the biopsy of the peritoneum. Okay, and we are also going to do colonoscopy. By doing colonoscopy, we can have a direct view of the colon. Okay, so whether the ulcers have developed in the colon, and if the ulcers are there, we are going to take out, we are going to do biopsy from the edge of these ulcers. We're going to study the nature of these ulcers. That is done by doing the colonoscopy. Clear? So let me repeat, what are the investigations? First, the basic blood investigations. We are going to do the chest x-ray to find out the focus in the lungs. Then we'll do x-ray. Okay, so x-ray, plain x-ray of abdomen, that is going to give us an idea whether there has occurred any intestinal obstruction or the calcified lymph nodes. Okay, ultrasonography, this is going to give us a detailed view of if there has ascites has developed, the lymph nodes, if there is lymphadenopathy, if there is thickening of the cecum, because this thickening of cecum and ileum, this is very common in cases of abdominal tuberculosis, whether there has occurred the thickening of cecum, ileum, right, whether there has occurred omental thickening. So all these things can be seen in ultrasonography. These things again can be seen with more precision when you do the CT scan, then ascitic fluid examination, biopsy of the peritoneum, and ultimately we do the colonoscopy, direct visualization of the colon. We can see the ulcers, we can take biopsy from those ulcers. Okay, so these are the investigations which is done in these patients of abdominal tuberculosis, right? Then next come last portion, that is, let's come to the treatment. So what is the treatment which is done? Remember the simple anti-tubercular treatment. The treatment which is done for the similar to pulmonary tuberculosis, the anti-tubercular treatment which is similar to pulmonary tuberculosis is done in this situation also. And if there has developed some complications, accordingly we have to manage. Like, as I told you, one of the main complications is the development of strictures. Okay, so if any portion of the intestine, like so let us just say here there has developed a stricture in this portion. Okay, so here in this portion we can carry out strictureplasty. Okay, strictureplasty. It is done for those strictures, not for all strictures, for those strictures due to which the lumen has been reduced by more than 50%. Okay, so in those cases we do the strictureplasty. Or in those, suppose a particular segment of the intestine, suppose let's say this segment of the intestine, like there are multiple strictures. Okay, so let us just say here there is a stricture, again here there is a little bit dilation, then again here a stricture. Little bit dilation, and again here there's a stricture. If there are multiple strictures in any one particular segment of the intestine, what do? Is that we simply resect out that segment. We remove that segment. Resection of segment if there are multiple strictures. Okay, and accordingly, if there has occurred perforation, you have to treat the perforation. Okay, so this is the treatment, basic treatment. Antitubercular drugs are given. If there is a development of strictures, do strictureplasty. If multiple strictures in one particular segment of the intestine, remove that segment of the intestine, resection of that segment. And if there has occurred perforation, then treatment of perforation. So this is your basic treatment. I told you the details about the abdominal tuberculosis. Clear? So abdominal tuberculosis, just a brief summary. It mainly includes which all things come under abdominal tuberculosis. If there is involvement of intestine, peritoneum, or the lymph nodes by the Mycobacterium tuberculosis bacteria. Okay, how it is spread, either hematogenous spread or direct ingestion of bacilli. Okay, or direct spread from the adjacent organs. Okay, so intestinal tuberculosis is further divided into 3 types: ulcerative, hypertrophic, and ulcero-hypertrophic. Clear? Similarly, peritoneal tuberculosis, where is the presence of this multiple yellow-white tubercles on the peritoneum, there occurs the omental thickening. Peritoneum is thickened. Okay, and again, it is of 3 types: the wet type, the encysted type, and the fibrotic type. Then you have got the lymph nodal tuberculosis. Lymph nodal tuberculosis, as I told you, here it is mainly affecting the mesenteric lymph nodes, the omental lymph nodes, and the peripancreatic lymph nodes. Clear? Next, come to the clinical features. Clinical features, as I told you, patient, the normal first, the basic ones, that is a fever, malaise, anorexia. Apart from that, in abdominal tuberculosis, patient can either have diarrhea or constipation. There is a colicky abdominal pain, okay, due to this strictures, luminal compromise. And there can be the presence of abdominal muscles because of this lymphadenopathy and this omental thickening, or there can also be the abdominal distension due to ascites. Okay, then we talked about the complications, where I told you this formation of strictures. Because of strictures, there can be intestinal obstruction, there can be perforation, there can be hemorrhage, there can be fistula formation. Okay, then we came to the investigations, where we did the basic blood investigations, the X-ray, the USG, CT scan, the barium meal. Okay, so where I showed you a number of signs, the chicken intestine, that I told you about the hourglass stenosis. Okay, I also showed you the spring sign, okay, and the Stirling sign. So these are the investigations which you will do: the CT scan abdomen, ascitic fluid examination, biopsy, colonoscopy, investigations which we do. And ultimately we came to the treatment, where I told you about this antitubercular drugs are given. And if there is development of strictures, we carry out strictureplasty. And if multiple strictures involving a particular segment of the intestine, we carry out resection of that particular segment of intestine. And if there has, then we accordingly do the treatment of perforation. Okay, so this is all about your abdominal tuberculosis.